Okay, Courtney, I'll do this one.
All right, this is a 66-year-old female. She has discomfort in both eyes and floaters, non-contributory medical history, just a hemorrhoidectomy. For systemic meds, Activella, calcium, multivitamins, Nexium, and her vision is 2025, 2032. Pressure is normal. And as a caveat, for when you're describing the fundus photos, there are other things going on. We're concentrating on the nerve findings, but feel free to just describe everything going on, just for completeness sake, I guess.
Sure. So here is a color fundus photo of the right eye. Media looks clear. Vessels look within normal limits. Attention is drawn to the nerve where it's kind of difficult to make out the cup to disc because it looks like there's almost some elevations, especially superior nasal there and some irregular borders there, but kind of looks like a small cup to disc, but a little bit difficult to make it out. And then attention is also drawn to the macula, in between the fovea and the nerve, where there looks like there's some areas of atrophy. And here is a color fundus photo of the left eye. Media is clear, vessels look okay. Again, attention is drawn to the nerve, where it looks like kind of irregular borders there, maybe some slight elevation looking at the blood vessels as well, again, superiorly there. Attention is also drawn to the macula. You can see there's kind of, almost looks like a stretching of the retina in between the nerve and the macula, perhaps either like a fibrovascular membrane or like an ERM kind of there.
Yep.
And
David just wanted to point out something in this photo.
yeah, go for it.
Yeah, it looks like there's a trifurcation of the vessels.
So
It may not be a normal branching pattern. I was looking for that. It's a little, like when you look at the if you trace the artery coming off the optic nerve, the other one's a little better, I think.
yeah, this one's better than
Yeah, the second eye.
Yeah.
I like the other eye, actually. So if you look at the vessel branching out, you can fall, like it goes here, right? And here, but then it also kind of goes over here. So you have like this extra, typically you go up, down, split, right? But now here you got three. So it's a little, the branching pattern is just a little bit weird.
Okay. So here is a fundus autofluorescence of both eyes. I'll do the right eye first. You can see attention's drawn to the nerve where you see several foci of hyperautofluorescence. That area of atrophy you can see is kind of hypoautofluorescent with an area of hyperautofluorescence superiorly there. And in the left eye, again, you can see the nerve where there's several areas of hyperautofluorescence, and then there's a few areas of hypoautofluorescence superior to the nerve.
Yep.
Sorry.
These numbers, they might be really tiny.
And I'm on my phone, so I'm like squinting, sorry.
Basically, they're all over, but I don't think this is a color one anyway, but all the numbers are kind of like less than 60, I'm pretty sure. I can't also.
Yeah, the right eye is 45
Yeah.
and the left eye is 50 for your RNFL thickness.
Yeah.
And you guys know what they're supposed to be about, roughly? RNFL?
Slightly greater than 80.
Yeah, like 80 to 100.
Yeah.
Typically 100, 90 is not bad.
Yeah.
80 is like the,
Yeah.
yeah, 50 is bad. 50, 45 is toward the lower limit of what it can
Yeah,
measure.
that's all you need to know from this slide. Okay. There's quite a few OCTs, so I'll just give you kind of a glimpse. You can see, okay.
Okay, so here is a OCT of the right eye. Looks like it's also going through the nerves, so probably like a raster OCT. You can see that there is some elevation of the optic nerve, and then there's kind of two areas like lateral to the optic nerve where there's some kind of material and like the superior retinal layers. And then you can see those areas of atrophy there where there's some loss of the RPE and hypertransmission defects as well. kind of same thing here, just more attention is drawn to those kind of subretinal conglomerates there on the nerve.
Yeah.
It's tricky reading an
It's hard
OCT.
to get over
Yeah, when you look at an OCT over the nerve, you're gonna have vessels. Most of what you see is vessels. So most of these little hollow areas are vessels, but then there's other stuff. I don't know if you're gonna talk about reading an OCT over the nerves is a real pain because we don't do it much.
I'm gonna
These-
talk about what allegedly you should be seeing.
Okay, yeah, it's very, I have a lot of trouble with this. And these are EDI OCT. So generally, if you feel like doing a scan over the nerve, it's nice to get, you mentioned raster. These are actually the line scans because they're optimized. So they reduce noise by doing 100 samples. And also they're EDI scans, so you get the full depth.
Awesome.
And similar findings over here on the nerve. You can see where that area where it looked like there was kind of traction on the retina, looks like there might be an ERM on top there, as well as that's either space or just some intraretinal fluid there. And same thing here.
Yeah, all pretty symmetric, kind of just a bunch of attempts to kind of show you like characteristic patterns for the nerve, and we can talk about it. Okay, so summary of findings here. So just like you said, fundus photos, some irregular margins without obscuration of the vessels, kind of hard to see like a cup to disc, and then the pigmentary macular changes. On autofluorescence, there were some focal areas of autofluorescence over the disc in both eyes, pretty symmetric. OCT, it's these discrete areas that have kind of a hyperreflective edge and then hyporeflective core, which is easier said than seen, I think. And then RNFL, there was just something in both eyes, not specific. So what differential are we working
So
with?
top differential diagnosis would be optic disc Drusen. Some other causes that could be like causes of optic nerve elevation could be like papilledema, IIH, neuroretinitis, just anomalous disc as well.
Awesome.
Nice.
And I think I don't have like the actual diagnosis in this differential. This is everything else it could be basically. But yeah, you got it. So basically, yeah, the biggest thing is differentiating from like true papilledema versus pseudopapilledema from another etiology. And then, yeah, you said it. And then maybe myelinated neurofibrillary, although obviously that looks different. And then you have crowded disc, but the margins are normally pretty clear for a crowded disc. Okay, so you got an optic disc Drusen or optic nerve head Drusen. There's actually two different iWiki pages that both have overlapping material, depending on which term you search. Basically, it's refractive nodules. I've gotten this question before. What are they made of? Mitochondria that calcify with age, so it's easier to see as the patient gets older. There's no gender predilection, typically bilateral, and it's often inherited. If it is, it's believed to be autosomal dominant, but with incomplete penetrance. So that's why you don't get like the exact same picture in every single person. I feel like those are all high yield to be asked about.
The autosomal dominant, honestly, is one of the hard things, which I bring a case in eventually, is when they're non-calcified in children.
Yeah.
Is a real bear. So if I have a kid with swollen discs in the mom or dad there, I'll usually look at the nerve.
Yeah. And or you can just like ask them like, how's your parent ask the parent, have you been told you have a weird nerve before or something? Because it is so often inherited. And also in kids, it's more buried and then it becomes less buried as people get older. So that's why it can look kind of strange in young people, but then it's very obvious if you see it in an older person. That's the reason you're not just crazy. Pathophysiology, it can be related to an inherited dysplasia of the optic disc. The key buzzword is flowed axoplasmic flow, and then it causes these like calcific nodules later on. It's often asymptomatic, but if they're gonna have symptoms, it'll be this non-progressive visual field loss, which corresponds to the RNFL that we saw. And then sometimes they can have transient visual obscuration. I think they said like 10% of the time. No, it's reading. So the diagnosis is a clinical diagnosis. The characteristic lumpy, bumpy optic disc appearance is the most obvious most of the time, but then you can confirm with B-scan, which will show that highly reflective, hyperechoic area with posterior shadowing, which I'm sure all of us have seen before. On FA, you get like a focal blockage and then late staining, but no leakage because there's nothing leaking here. It's just staining the drusen. OCT is not necessary for diagnosis and obviously very difficult to get right over the drusen, but the early detection of RNFL thinning can be predictive of visual field loss, so it's helpful to get sometimes. And then the most important thing, like I was alluding to earlier, is you have to distinguish it from true papilledema. So the three main ways are, is the disc hyperemic? In true papilledema, the disc will be hyperemic. I think we saw in both of these, the disc was not. You have microvascular abnormalities on the surface of the disc, or like flame hemorrhage in true papilledema. And then obscuration of vessels and blurring of the disc margin, which I think all of us know to comment on the absence or presence of when we're doing all of our papilledema evals every single day at TGH. So that's the reason why I do that. Management, you can get a baseline visual field just to be able to track if for those people who are gonna have that non-specific visual field loss, you can get RNFL if you're suspicious for thinning. There's no effective treatment, it's just observation, serial observation. The very rare complications that are associated, just in case you get asked, you can get rarely a CNVM formation and rarely NAAION is also associated with optic Drusen. These are my references, and then some characteristic pictures, that hyperechoic area with posterior shadowing, and then the lumpy bumpy.
Yeah, do you guys really get visual field when you diagnose this or no?
So I feel like me diagnosing in clinic is not that common because almost everyone already has it. They're just there for like repeat observations. They've gotten a visual field at some point.
If you
in
had
their
a new
life.
one, would you think you would get one?
Probably.
Yeah. Do you get visual fields when you get new ones?
It's like, I get some RNFL.
I get RNFL and I tell them about CNV more than visual
Yeah,
field
could get
things.
I wonder if it depends on what clinic you're in for what you.
Yeah, in neuro clinic, you would definitely
Yeah.
get a visual field.
Yeah.
Retina clinic, you probably wouldn't get a visual field.
Yeah. Although articles look so great, I feel like my bar going.
So in a young child, this would not show.
It's a bear in a young child, so I'll bring one of those in, but I get a fair number of these for evaluations. The recent literature is typically, I don't think they calcify till you're probably 20 or 30. So you get these 12-year-old kids who come in with these fat nerves, and is it pseudopapilledema? My understanding, having really read a bunch on this, is that the best test is a fluorescein angiogram. And what you find is that the nerve should leak if it's papilledema and it doesn't leak in pseudo.
I have a guy like
That's your gold standard.
hardest case
The problem is some of them are mixed.
Yeah, I have one hard case like this that has real Drusen. He's in his 30s now. He presented like 10 years ago. He has these and he has PTC. So he has both
Right.
swollen nerves and this Drusen. And it's hard to say which is which.
Oh, you didn't talk about the line scan over the nerve. They're looking at the Drusen.
Oh, well.
You did.